Hello, my name is Gary Ulaner, and I am the Director of Molecular Imaging and Therapy at the Hoag Family Cancer Institute in Newport Beach, California. Today we'll be discussing FDG PET-CT for patients with breast cancer, particularly where is its greatest clinical impact. Here are my disclosures. I also disclose that I teach FDG PET-CT. I believe in teaching FDG PET-CT early. Here's my son, Ilya, and my daughter, Annabelle, who will both be outstanding molecular imagers if they choose to be. So let's talk about FDG PET-CT for patients with breast cancer. We'll talk about the staging of breast malignancy, the TNM staging, tumor, node, metastatic disease. Then we'll talk about the evaluation of treatment response in patients with breast cancer, and then talk about the contribution of tumor histology in the interpretation of FDG PET-CT. We'll start by talking about staging of the primary malignancy, T staging. So on FDG PET-CT, if the primary breast malignancy is large enough, you'll see it both on the FDG PET as well as the CT component of FDG PET-CT. However, it is well known that for smaller but still clinically important primary breast malignancies, it will not be seen on neither the FDG PET nor the CT component of an FDG PET-CT, but may rather be easily visualized on mammography, as well as breast MR or ultrasound. So it is known that the FDG PET-CT is not sensitive for detection of the primary breast malignancy. In addition to being not sensitive, it is also not specific for breast malignancy. Even physiologic breast parenchyma may demonstrate FDG avidity, which is not malignancy, but rather is background physiologic activity. And certain inflammatory states can demonstrate substantial FDG avidity, which is benign and should not be confused with malignancy. For example, this patient with breast cancer post-lumpectomy and axillary lymph node dissection demonstrates markedly FDG avid soft tissue in the left breast axillary tail and axilla, which can be seen on the FDG PET as well as the CT. And this is post-surgical inflammation, which should not be mistaken with residual malignancy. As can be seen several months after the surgical changes, the FDG avidity resolves, and the residual soft tissue decreases in size, and this is benign post-surgical inflammation. One potential tip-off of post-surgical inflammation can be seen on the CT when macroscopic fat is seen in the soft tissue. In this patient with mastectomy and flap reconstruction, we can see FDG avid lesions at the border of the mastectomy bed, but these lesions have macroscopic fat within them. Breast tumors don't have macroscopic fat within them, so this is a good tip-off that this is benign fat necrosis at the margin of the surgical bed and post-surgical inflammation. You can detect malignancy within the breast on FDG PET-CT. However, it isn't always breast cancer. Here's an example of a patient with lymphoma, and there's an FDG avid large lymphomatous mass in the pelvis. An FDG avid nodule is seen within the breast of this patient. Could this be benign? It could be. Could it be breast cancer? It could be. Could it be something else? It could be. So mammography and ultrasound is the appropriate workup for an incidentally identified FDG avid lesion within the breast. And this patient underwent mammography, ultrasound, and subsequent biopsy. This one turned out to be a synchronous primary breast malignancy. So this was lymphoma, and a incidental breast malignancy was found on the FDG PET-CT. So incidental foci of the breast can be either benign or malignant, and the appropriate workup is a dedicated mammogram and or ultrasound, depending on the age of the patient, and biopsy when appropriate. So for the primary tumor, both the sensitivity and the specificity of FDG PET are low. So we're not very good for evaluating the primary tumor. If it's large enough, we'll detect it, but there are lots of tumors that we'll miss, and there are lots of things within the breast that are FDG avid, which are benign. So specificity and sensitivity of FDG PET is low. And of note, if you do find an incidental FDG avid breast lesion, it should be evaluated by mammography and/or ultrasound, and then subsequently biopsied. Let's move on to end staging, local lymph nodes. We'll break this up into the axilla and extra-axillary lymph nodes. Here's a patient with a primary breast malignancy which is visualized on the FDG PET, and we can see there are no FDG avid lymph nodes within the axilla. However, on a pathologic evaluation of the axilla through a sentinel node biopsy, it was found that this patient does have axillary node metastases. So here we were not sensitive enough in order to pick up malignancy on either the FDG PET or the CT. So like for the primary breast lesion, axillary nodes, we are not sensitive for axillary nodal metastases, particularly compared to pathologic evaluation by a sentinel lymph node biopsy or axillary dissection. However, our specificity is reasonable. So here is a sub-centimeter node, which may not be considered suspicious on CT, but the presence of FDG avidity within this node makes it suspicious for a lymph node metastasis, which was subsequently pathologically confirmed. So in the axilla, FDG PET has poor sensitivity, but good specificity. We don't pick up all the lesions, but if a node is FDG avid, that's pretty good evidence that you do have axillary node metastases. What about extra-axillary nodes? Well, here is where FDG PET-CT really starts to add clinical value, because the extra-axillary nodes are not evaluated in that sentinel dissection. Here's a patient with breast malignancy and a new sub-centimeter, mildly FDG avid internal mammary node. And this is localized by ultrasound and biopsied and turns out to be a previously unrecognized internal mammary lymph node metastasis, which can change the end staging of the patient and thus the clinical care of the patient. So FDG PET may find extra-axillary lymph node metastases, such as internal mammary or infraclavicular, supraclavicular nodes, and this can impact patient management. A few things to be aware of. FDG avidity in lymph node basins should certainly be compared with a CT. And here we can see this does not appear to be a lymph node. It looks like more a patchy soft tissue opacity. This is post-surgical change within the axilla, similar to the post-surgical change that we saw within the breast. So here is benign post-surgical change in the axilla, not an FDG avid node. What I like to tell residents is you can't have an FDG avid node without a lymph node. So if there's no node on the CT, particularly in the axilla or the internal mammary region where you can usually discern the node from local fat, then it's very difficult to have an FDG avid node. In the mediastinum, particularly when there's no contrast on the CT, it may be very difficult to distinguish nodes from the local vasculature, so nodes can kind of hide there on non-contrast CTs. Other things to be wary about. Here's multiple FDG avid nodes in the mediastinum and hyla, but notice this very symmetric distribution, and it is not in the expected distribution for nodal metastases of breast cancer. For example, breast cancer we expect in the axilla to have nodal metastases or the internal mammary lymph node basin. It is incredibly unlikely for you to have mediastinal and hylar metastases without any axillary or internal mammary metastases. So this is benign FDG avidity in lymph nodes from granulomatous disease such as sarcoid. So look out for sarcoid, because in this particular patient, this was misinterpreted as possibly malignant, and the patient underwent a mediastinoscopy and biopsy, which of course demonstrated benign sarcoid, but the patient had a vocal cord paralysis side effect from the mediastinoscopy, which could have been entirely avoided if the FDG PET-CT had been appropriately read. Another potential pitfall to look out for is this. Here's an FDG avid node. However, the node is incredibly small on CT. This would be very unlikely to contain enough malignancy for it to be FDG avid. If we look at the corresponding maximum intensity projection images from the PET-CT, we can see the FDG avidity in the left antecubital fossa. This is extravasation of tracer at the injection site. And then that extravasation travels through the lymphatics and accumulates within a node within the axilla. So in a sense, we did a sentinel node exam of the arm. Right? Normally, we inject some radiotracer into the breast, and we see which is the first lymph node which drains the breast. Here, we unintentionally injected the arm soft tissue and identified the sentinel node draining the arm. So this doesn't necessarily represent malignancy in this node. It's just the draining node at a site of extravasation. So be wary of extravasation causing false positive nodes. Good. So we discussed the primary tumor. For nodes, we separate them into axillary and extra-axillary. For axillary nodes, our sensitivity is low, particularly compared to pathologic axillary sampling. For specificity, our specificity of detection of axillary nodes is good. And for extra-axillary nodes, both our sensitivity and specificity are good, and we pick up we may pick up extra-axillary nodal metastases which were previously unrecognized prior to the FDG PET-CT, and this can change clinical management. So that's pretty clinically impactful. Let's move on to where FDG PET can have the most clinical impact, and that is the evaluation of distant metastases. Here's a patient that has a primary breast malignancy, which is FDG avid, and on the FDG PET maximum intensity projection image, there's a focus in the pelvis on cross-sectional images that appears to be within an osseous structure, the right humeral head, and this turns out to be a biopsy-proven osseous metastasis, which was not known prior to the FDG PET. So this patient gets changed from a locally advanced malignancy, which would be treated with neoadjuvant therapy and surgery, to a stage 4 metastatic patient, which may forego surgery and go on to palliative chemotherapy. So the detection of a metastasis with the FDG PET made a huge impact on this patient's care, entirely changing their initial stage, their prognosis, and the way that the patient is treated after diagnosis. Now, some people would say, well, we can't see the lesion on CT because we know CT isn't so good for osseous metastases, but we might have picked this up on bone scan, and I show this patient's corresponding bone scan, and the lesion is not seen on bone scan. So the FDG PET is more sensitive for detecting osseous metastases than bone scan, and this is one reason why FDG PET-CT is in many places replacing CT and bone scan for the evaluation of distant metastases in patients with breast cancer. So there are multiple prospective clinical trials now demonstrating that for locally advanced breast cancer, such as stage 3 breast cancer, FDG PET improves the detection of previously unsuspected distant metastases, and this has a huge impact on clinical management. As the locally advanced tumor is increasing in stage, there's a greater chance of us finding those distant metastases, and it changes the stage by finding extra-axillary lymph node, and as we said, distant metastases. To compare FDG PET-CT with CT and bone scan, this is a nice manuscript out of Memorial Sloan Kettering Cancer Center, in which whenever patients had both an FDG PET-CT as well as a bone scan and CT to compare, when there was discordance between the FDG PET and bone scan and there was pathology to confirm what was true, the FDG PET-CT was always correct over the bone scan. So FDG PET-CT may be supplanting bone scan for the evaluation of metastatic breast cancer. A few things to be wary of when you're evaluating the bones. Here's a patient with a breast cancer, and there's bilateral FDG avidity in the sacrum, but nowhere else within the spine. This is further evaluated by MR, and we can see on T1 imaging that there's preservation of some high signal fat. So this isn't replacement by tumor, but rather this is sacral insufficiency fractures, not malignancy. This has often been described as the Honda sign, where you see the H within the sacrum. With sacral insufficiency fractures, you don't have to see a complete H. You might only see the two sides of the H without the crossbar. You might see one side with the crossbar, or you might only see one side. So when you're looking at the sacrum, be wary of sacral insufficiency fractures. And on the CT, if you flip the CT from axial to coronal images, you can sometimes see that fracture line, as it is right here, and be more certain that this is benign sacral insufficiency fracture, not osseous metastases. Another thing to worry about in the evaluating of the osseous structures is this case. There's FDG avidity within the osseous structures, but this is not FDG avid osseous malignancy. Correspond it with the CT that comes with the FDG PET. Look at the osseous changes. There's expansion of the bone. There's thickening of the cortex. There is a coarsening of the trabecula. This is the classic CT appearance of benign Paget's disease, and this should not be confused with FDG avid malignancy, because you could accidentally overcall malignancy and adversely affect patient management. Outside the bones, if we look at the liver, FDG PET may demonstrate hepatic metastases, which can be missed on CT, even in this contrast-enhanced CT. Why might this be the case? Well, take a look at the attenuation of this liver. It's low compared to the spleen and muscle. So this is a liver with hepatic steatosis. Remember that liver metastases are often low attenuation on the contrast-enhanced CT. So low attenuation hepatic steatosis can hide low attenuation hepatic metastases. So this is one example of where FDG PET may detect liver metastases that are missed on the corresponding CT. The reverse may also be true. Here's an example of a baseline with a follow-up FDG PET CT. I don't see any lesions on the FDG PET. However, on the follow-up, particularly if you evaluate the liver on a liver window, we can see the new hepatic lesion, which turns out to be a biopsy-proven hepatic metastasis, which is first visualized on the CT component of the PET-CT and not yet apparent on the FDG PET. So I recommend, when evaluating the liver, make sure that you evaluate the liver on a liver window. Even on a non-contrast CT, you may pick up hepatic metastases on the CT component of the FDG PET, which aren't yet avid. How about we move on to the lung? In the lung, often the CT component of the exam trumps the FDG component of the exam. Here we see multiple FDG avid abnormalities in this patient with breast cancer. Two of them are round nodules in the lung, which are lung metastases, whereas here this is a linear fibrotic changes in the anterior lung from post-radiation pneumonitis, radiation inflammation in this patient who had a mastectomy, and then radiation to the mastectomy bed. So again, FDG avidity could represent either malignant or benign processes, and always compare with the corresponding CT that comes with your exam in order to help distinguish what's malignant and what's benign. For the pleura, an important comparison between something benign and malignant in the pleura. Here is its FDG avidity in the pleura, but on the comparison we can see this high attenuation within the pleura. This is the talc from talc pleurodesis, and this may remain FDG avid for many years, or even the extent of the patient's life. So the high attenuation talc on the CT images demonstrates that this is benign, almost certainly benign post-pleurodesis inflammation, compared to this, where we see, again, FDG avidity in the pleura. Looks exactly like the prior case on the FDG PET. However, on the CT, we can see the thickened pleura without high attenuation, as well as the presence of a pleural effusion demonstrating that the pleura is kind of angry. So this is almost certainly active pleural malignancy, whereas in the prior case, you see benign post-pleurodesis inflammation, and it looks exactly the same on the FDG PET. Again, you're using the corresponding CT findings in order to determine whether this is benign, such as this case, or malignant, such as this case. These are two great examples on boards, by the way, where they get you to distinguish benign post-pleurodesis inflammation from pleural malignancy. So we've already talked about the tumor and the nodes. For metastases, FDG PET has excellent sensitivity, probably the best method for being sensitive to detect distant metastases, and the specificity is also very good, particularly when you're using the CT scan to correlate with FDG PET findings in order to exclude benign causes of FDG avidity. So make sure to compare your CT findings with the FDG PET. And we've also noted that there's a growing data that demonstrates the FDG PET CT is better than what the current clinical standard CT bone scan for staging patients with breast malignancy. So let's start building this. Where is the clinical impact of FDG PET in patients with breast cancer? Well, patients with locally advanced disease at initial diagnosis, the FDG PET will detect distant metastases in about a third of them. That changes their locally advanced stage to a distant metastatic stage, and that obviously changes their management dramatically. In patients with stage 2B disease, there's a lower extent of upstaging, so it's debatable whether FDG PET should be considered at stage 2B, but there's a growing faction requesting FDG PET for stage 3 breast malignancies in order to exclude previously unsuspected distant metastases. Now let's talk about treatment response of FDG PET in patients with breast cancer. And for that, we can divide it into the primary breast malignancy and then, of course, the distant metastases. So there are multiple manuscripts demonstrating that for the primary breast malignancy, FDG PET can predict response versus non-response. So if the FDG PET of the primary malignancy is decreasing, that means that the patient is responding to the neoadjuvant therapy. But in general, this doesn't have much clinical impact because after the neoadjuvant therapy, the patients go to surgery, and it's the surgical pathology that truly determines whether the patient had no response or a partial response, PR, or a complete response, CR, and you're only making guesses with the FDG PET whether you're a PR versus CR, whereas the pathology is more definitive. So you can see treatment response on the FDG PET, but the pathology trumps the FDG PET within the breast itself. Now, for distant metastases, FDG PET has a substantially more clinical impact. Here's an example of a patient systemic therapy and post-systemic therapy. The post-systemic therapy demonstrates new sclerotic osseous lesions, which could be interpreted as new osseous metastases. However, if you add the FDG component of the FDG PET, you can see that actually this patient had FDG avid metastases which were not apparent on the CT, and after chemotherapy, the new sclerotic osseous lesions are actually treatment response, not new metastases. So the FDG PET here can entirely change the interpretation from the CT suggests new metastases. The FDG PET demonstrates this is not new metastases. These were prior metastases that are now well treated. Very important clinical distinction obtained with FDG PET. This can, different patterns for this. You can go from CT occult and FDG avid to non-avid. You can go from FDG avid lytic lesions to non-FDG avid sclerotic lesions. This on CT is more apparent that this is a treatment response. When it goes from lytic to sclerotic, you say that's a treatment response, even without the FDG PET. Or here we have FDG avid sclerotic osseous metastases that become more sclerotic on CT, so they could be mistaken for increasing osseous metastases, whereas the FDG PET shows you this is actually excellent treatment response with increasing sclerosis from osseous healing. So again, increasing sclerotic lesions or new sclerotic lesions on the CT could be new metastases or treatment response, and the FDG PET is far better at distinguishing whether it's just a treatment response versus whether it's new metastases. All right. So for patients with osseous metastases, treated bone metastases are known to become non-FDG avid, and this is far more predictive of response than what occurs on the CT. In addition to monitoring treatment response, we can also monitor increases in disease better with FDG PET than on CT. Here's a baseline CT, follow-up CT, very difficult to discern a change, but here's the corresponding FDG PET, baseline and follow-up. It's very easy to demonstrate this patient has substantially increased osseous metastases. And this makes a difference in patient care. So here where we're looking for, if we're looking at RECIST versus changes in FDG PET, when you have a RECIST responder, for example, CT response versus CT non-response, we can definitely see a prediction of survival. However, the FDG PET response versus FDG PET non-response is far more predictive of what's happening to the patient, and thus far more valuable in determining how to manage the patient further. FDG PET can also be more valuable for detecting recurrent disease in patients with presumed treated malignancy. Here's a patient with breast cancer and an increasing tumor marker, baseline CT, follow-up CT. I can't see where the new malignancy is, but here's the baseline PET, the follow-up PET. Here's the biopsy-proven recurrent malignancy. So the FDG PET is far better at detecting a malignant recurrence than the CT, and this has been demonstrated in prospective clinical trials that the FDG PET is superior to CT and bone scan for detecting recurrent breast cancer. So where is their clinical value in FDG PET CT for patients with breast cancer? We've discussed the initial staging. Here is a stage 4 metastatic disease. The FDG PET is more accurate than CT bone scan for evaluating treatment response and recurrence in patients with breast cancer. So patients with metastatic breast cancer is a great application of FDG PET CT to determine whether the patient is responding or getting worse after their therapy. Let's briefly talk about tumor histology, particularly lobular breast cancer. The most common breast cancer is ductal breast cancer, and ductals are about 80% of all breast cancers. But many people are unaware that lobular breast cancer, which makes up about 15% of breast cancers, is very different than ductal breast cancers. So when you're reading studies, you usually just get a clinical history of breast cancer. And one of the first things I do is I look at the histology to determine if it's ductal breast cancer or the less common lobular breast cancer or some other form of breast cancer. Lobular breast cancer is known to show loss of CDH1, which codes for E-cadherin, which is a cell adhesion molecule. So it holds, when you lose that cell adhesion molecule, the tumor cells don't grow in tight balls like they do in ductal cancer. They tend to grow out in less cohesive lines, so there are fewer cells per unit volume of soft tissue, and this makes lobular breast cancer more difficult to detect on mammography, ultrasound, breast MR, and also FDG PET. So here's an example of an FDG PET-CT where there are no abnormal FDG avid foci, but there are multiple sclerotic osseous foci on the CT. Are these benign bone islands, such as osteopoikilosis, or are these non-FDG avid osseous metastases? Well, the patient had imaging from prior to their breast cancer and after the diagnosis of breast cancer, showing that these lesions are new, and thus these are not benign bone islands. This is biopsy-proven osseous metastasis, which was not avid on the FDG PET. So be wary. Lobular breast cancer is often less avid than ductal breast cancer, and it has to be detected on the CT component on the FDG PET rather than the FDG PET. Here's an example of a patient, again, with no abnormal FDG avid foci, but extensive thickening of the stomach, peritoneal free fluid. This is unfortunately widespread peritoneal carcinomatosis lining the GI tract, which is not apparent on the FDG PET, but is apparent on the CT component of the study. So the majority of lobular breast cancers are FDG avid. However, there is a substantial minority, maybe a quarter to a third of them, which are not FDG avid. So be wary when reading FDG PET studies on patients with lobular breast cancer that the FDG PET may not be as valuable for evaluation of lobular breast cancers as they are for ductal breast cancers. So let's wrap this up. Knowing that what we have discussed, what are the National Comprehensive Cancer Network guidelines for using FDG PET in breast cancer? Well, about 5 to 7 years ago, the NCCN said do not use FDG PET-CT. However, we have luckily advanced from don't use it to it is now optional, because they say the FDG PET can help identify unsuspected regional nodal and distant metastases. That's for initial evaluation of breast cancer. How about for metastatic disease? Again, 7 years ago, the NCCN said don't use FDG PET, but we have advanced to being called optional for the same reason. We can detect nodal and distant metastases better on FDG PET than you can on CT and bone scan. And it is my hope that maybe in another several years, we can convince the NCCN to making FDG PET a preferred method of evaluating breast cancer at initial diagnosis for locally advanced disease, as well as for metastatic breast cancer. That is, unless someone comes up with a better way of detecting distant metastases in breast cancer. It's kind of like if someone builds a better mousetrap. So here's my little summary of the clinical value of FDG PET in patients with breast cancer. For patients with advanced local disease at initial diagnosis, FDG PET will find unsuspected distant metastases in approximately a third of them, and therefore should be considered for the initial staging of locally advanced breast cancer in order for patients to get the appropriate stage at diagnosis and thus the appropriate treatment. And for known metastatic breast cancer, FDG PET-CT appears to be more accurate than CT bone scan for evaluating treatment response and recurrence, and can be a very valuable modality with great treatment impact in patients with metastatic breast cancer. The warning: beware of lobular breast cancers, which may or may not be FDG avid, so the lobular breast cancers can be missed on FDG PET. Here's a review article which I published talking about additional factors for the clinical value of FDG PET-CT in patients with breast cancer. I thank you very much for your attention. Here is my email in case anyone has any questions. I hope that you are able to use FDG PET-CT to improve the clinical care of your patients with breast cancer. Thank you very much.